we will jump right in. All right, so the objectives here, we're going to discuss the indications of an epinephrine push, review the process of creating an epinephrine push. So how would you actually do this in a situation where you would have to do a push dose pressor type agent? How would you reconstitute that and then administer the correct amount? Because we're going to be converting from milligrams into micrograms. And I know that that sometimes becomes a little bit overwhelming for people if they're not used to doing that. But in the grand scheme of things, it's actually a pretty simple process to do. And we'll talk about how to do that. We're going to review the Epi Push dose, what the actual dosage recommendations are. We'll talk about the setup and the benefits of a dirty Epi Drip. This is something that was kind of added in after the presentation was made. So the situation where we may end up doing a dirty Epi Drip is where you have limited people, you need to get some epinephrine on board. I'll go over how you can mix epinephrine into an infusion and then run the infusion in. And you'll see when we get to that portion, obviously we need to make sure that we're following our protocol, or you at least have the authorization of online medical direction to do that in the event that you determine that the patient is in need of an epinephrine infusion. And then lastly, we're going to talk about the magnesium sulfate. And this is because even though we've carried it for years, unless you've had a patient that has an eclampsia type situation, potentially an asthma situation, most of us probably have not given magnesium sulfate very routinely. So we wanted to cover that medication so that people were a little bit more comfortable with it regarding the classification, indication, contraindication, and then dosaging. So Epi Push versus dopamine. So I know for a lot of us, and actually even in today's world, the dopamine infusion is still something that is testable material on the National Registry. If you're in a situation where you're going to be testing, we can kind of talk offline if you have questions about how to figure out dopamine dosaging. But in today's world, most people are probably going more along the lines of the Epi Push or push dose pressors. You'll see that kind of abbreviated as a PDP, and that's what that stands for. So what I think is important to remember about the push dose epi and dopamine is that both of them have alpha and beta stimulation. So, and when we talk about beta stimulation, if we can review the beta 1 and beta 2, and you also have alpha 1 and alpha 2. And I know that in entry-level paramedic education, we don't typically talk about alpha 1. We don't typically talk about alpha 2. We talk about alpha 1 when we mention alpha effects. So when you were being taught about dopamine or you were being taught about epinephrine and your instructor was telling you it has both alpha and beta effects, really what they're talking about in that situation is primarily alpha 1. And alpha 1 gives us vasoconstriction. Alpha 2 actually gives you a little bit of mild vasodilation, which can be known to help to drop blood pressure. So it's kind of counterintuitive, but epinephrine and dopamine do both have both alpha 1 and alpha 2 effects. And then when we talk about the beta effects, we know that we have one heart. So beta 1 deals with your one heart, and then beta 2 is your two lungs, and that is where we get the bronchodilation. So with dopamine, the effects are largely based on how much how much dopamine is actually going to be administered to the patient. So if we're talking about dopamine being administered at 1 to 2 mics per kilo per minute, you're basically getting dopaminergic effects. And when your dopaminergic effects kick in, generally speaking, what's going to happen is you're going to get some increased blood flow to the kidney or the renal system, but you don't really get the effects that we're looking for from the pre-hospital aspect as far as trying to increase either heart rate or blood pressure, which are the two things that we're primarily focused on and worried about in the situation where we would be administering epinephrine or dopamine. So if we bump that up a little bit and we're at the 2 to 10 mics per kilo per minute, we're basically getting beta effects. And beta effects, remember, beta 1, your one heart, is going to be a positive ionotropic and positive chronotropic effect. So ionotropic is squeeze, how much squeeze you're getting, and then your chronotropic effects are going to be how regular the heart rate will become, how much you're going to increase that heart rate, and that is chronotropic effects. And then with beta stimulation, we're also going to end up getting the beta 2 effects here, which is going to be bronchodilation. Once we get into 10 to 15, we're getting some alpha effects. Alpha 1, as I told you, is going to cause vasoconstriction, and that is going to help to increase blood pressure. So I know for many, many years teaching paramedics in initial entry paramedic education, my thought was always in the pre-hospital setting, if you're starting dopamine, we should really be starting it at 10 mics or greater. I like the number 10 because it's easy to work with. We can figure it out based on 10 per kilo. People can do the simple math and then figure out how many drops per minute this is going to end up needing to be. At 10 mics, though, remember, we're getting alpha effects, vasoconstriction, so our blood pressure comes up, and we get beta effects, so we get that positive squeeze, we get an increased heart rate, and we get a little bit of bronchodilation. So from my perspective, and my thought has always been, if you're starting dopamine in the pre-hospital world, we need to think about at least 10 mics per kilo per minute. And I think that that is true 100% of the time, unless your protocol or the online physician tells you a different dosaging. I would strongly recommend that we start off at 10 mics per kilo per minute. The dose of an Epi Push is consistent and therefore produces consistent effects. This is a little bit different than what we find with our dopamine, because dopamine, obviously being dose dependent, it depends on how much we're actually giving as to what your effects are going to be. And then studies that are out there, some of them suggest that dopamine has an increased risk of cardiac arrhythmia, where we don't necessarily find that with our push dose epi, but I will tell you that some of the data is limited at this point. So we may end up finding later on, as we get down the road here, that there are some, in fact, untoward effects from the push dose epinephrine, just like there is with the dopamine administration. And then dopamine's onset is 2 to 4 minutes, whereas with the push dose epi, you're getting an onset of about 1 minute. So it's a little bit quicker onset. But as I mentioned before, we don't really have a lot of strong data, especially in the pre-hospital world. The data that is out there with push dose pressors primarily comes from the operating room. So even in the emergency department setting, there's still not a lot of great data out there. But certainly as more people continue to do this and as it takes off and finds its place in medicine, I think that we will start to see more of the data start to come forward. So I've already kind of mentioned this as far as your sympathetic or your adrenergic nervous system, the two different types of alpha receptors and the two different types of beta receptors. So I'm not going to rehash that with you. The alpha 1 receptors, as I told you, is vasoconstriction. And when with that, you may get a little bit of pupillary dilation. You may get some decreased renin secretion. We know that renin is the renin and angiotensin and aldosterone system, and that ultimately is what takes the angiotensinogen and turns it into angiotensin 2, which is a potent vasoconstrictor. So if we reduce that, it doesn't have the ability to release some of the angiotensinogen like we would want to do in a situation where we are volume depleted. So your alpha 1 receptor, if you can just kind of remember, alpha 1 is really vasoconstriction. That's what you need to get out of that portion. As far as your alpha 2, there are medications out there that are alpha 2 receptor effectors. Catapres or clonidine is one. So any of your hypertension medications, some of them may fall into this classification, but we just don't talk about it that much. And as I told you, basically it's an autoregulation thing. It's a negative feedback system. So the whole goal here is these alpha 2 receptors are actually going to work on lowering blood pressure kind of through the mechanism that I mentioned just a few minutes ago. So as I told you before, it's a little counterintuitive because alpha 1 is getting the squeeze and alpha 2 is actually what is giving you a little bit of vasodilation and therefore the ability to treat some of the hypertensive patients that you may encounter. Beta 1, you guys have all heard this many, many times, I'm sure. Sorry. Beta 1 is going to be located in the heart, and that's your inotropic and chronotropic effects. As I told you, I'm not going to spend a ton of time here because we've already talked about some of these things and how they end up working. And then your beta 2 is your 2 lungs. So this is where we're going to end up getting a little bit of a reduction in the uterine and GI smooth muscle. So we're going to be able to breathe a little bit easier. Things are going to move forward a little bit easier depending on which part of the body we are actually affecting. So there is going to be some vasodilation with that, but for the most part, what we focus on from the EMS world is going to be the bronchodilation that may go along with that, or hopefully goes along with that, which is why if we're talking about a patient that has asthma, anaphylaxis, anything like that, some sort of a respiratory difficulty, we certainly want to make sure that we're giving a medication that has the ability to give that beta-2 agonist effect to where we can get bronchodilation and the patient can breathe a little bit easier. All right, so how would we make a push dose epinephrine? So you guys are familiar with Epi 1:1 and you're familiar with Epi 1 to 10,000. And after Dr. Antevi's talk, you know, he made a mistake giving some of these medications, and some of us have done that in the past. But basically what we want to do now is try to figure out how we're going to end up giving a medication that we can actually push to a patient. And if memory serves you, we should really withhold pushing Epi 1 to 1,000 or Epi 1 to 10,000 in any type of IV situation if the patient has a pulse. Well, that is no longer going to be the case. If we're talking about push dose pressors, the situation, and we'll look at a slide here in just a few minutes that talk about why we would do some of these things, and the answer is really shock. So if you have a patient that is in any type of shock and you need to try to get their blood pressure up, you're trying to get their heart rate up a little bit and give them a little bit of assistance until you can get things put onto a pump, or until you can get them to an emergency department where they can give them other medications, maybe like Epinephrine or Levophed, or there's a bunch of different medications out there that can potentially be used that we just simply do not carry in the field. This may be kind of the stopgap from point A to point B. So how we would make the push dose pressor is basically you're going to end up taking a 10 cc syringe that is empty, and you're going to end up pulling up 9 cc's of normal saline. And then you are going to end up taking your 1 to 10,000 epinephrine, and you're going to take 1 cc from that. So we have 9 of normal saline and 1 cc of Epi 1 to 10,000. And this is what we're going to end up doing to reconstitute that. If you guys remember that in this 10 cc syringe of epinephrine, it is a 1 in 10 ml. That is 1 milligram. So when this is remixed, this is going to end up being a 10 microgram per milliliter concentration, because now we are adding 9 cc's of normal saline to that. So it ends up giving you a 10 mic per ml, which is what we are wanting to convert to. Remember, we're trying to push this in micrograms, not in milligrams. And what we are looking for ultimately, depending on the literature that you read or the protocol that you're following, if you're pushing any type of epinephrine, you're probably looking for a range of somewhere in the neighborhood of 5 to 20 mics is what you should be thinking about delivering. So if we have a 10 mic per ml concentration, that should make giving 5 to 20 a fairly easy process for all of us. So here's what we're going to do. We're taking the epinephrine. We have a concentration of 0.01 milligrams per ml. And then once we draw that up and it's now in our normal saline, it gives us that 10 mic per ml concentration. And then this is going to end up being given in increments of 0.5 to 2 mLs. And if you do that, that is going to equate to that 5 to 20 mics that the patient should be receiving. And we should do this about every 2 to 5 minutes. So it's much like giving epinephrine in a cardiac arrest situation. But remember, these are your patients that are having a little bit more difficulty. They do, in fact, have a pulse. They just need a little bit of support and assistance until you can get them to a receiving center or figure out a different medication for them to get. So I just want to kind of clear this up, because I know when we're talking about the different medications, concentrations, sometimes it gets very confusing, especially if you're a hands-on learner and you're not actually drawing the medication up. So here goes again. Take 9 of normal saline, take 1 cc of your epinephrine, 1 to 10,000. That will give you a new concentration in that syringe of 10 mics per ml. And we are looking to give a dosage of 5 to 20. So if you wanted to give 10 mics, then you would essentially end up administering 1 cc of that new medication that you have just made. And we would end up doing that about every 2 to 5 minutes until another person takes over or you get them to tertiary care, etc. So why would we do this? Well, hypotension. So if the patient is hypotensive and we need to try to get their blood pressure up so that they can perfuse their end organs, then this is a situation where maybe your push dose pressors would come in. And maybe it's something that we're trying to just get them to that permissive hypotension level, that 90 millimeters of mercury that you see at the bottom of your screen, trying to get a systolic blood pressure to at least 90. I know that we have done talks in the past about what an adequate blood pressure is. And if you know my personal feeling on it, it isn't really even blood pressure we should be talking about. It should be the mean arterial pressure, which is the number in your parentheses on your digital readout from your blood pressure after it's been taken. And if you can just kind of keep in mind that if you have a mean arterial pressure, that number in parentheses is less than around 60, we know that the organs are not being perfused adequately. So it may be a situation that if your mean arterial pressure has dropped and it is no longer 60, depending on what the situation is with the patient, a push dose pressor may be something that you should consider, or at least call in and ask medical direction if it would be appropriate for you to do. I already mentioned shock. As far as the shock states, the different types of distributive shocks, so sepsis, anaphylaxis, and neurogenic shock, cardiogenic shock, and then post-resuscitation. So if you were able to get ROSC on a patient and they need that support until you get them to tertiary care, then push dose pressors may come in at that point. I mentioned this before, but I do want to be clear about this. The information that is out there is pretty favorable so far, although I should tell you that most of that information does come from the operating room and not necessarily even from an emergency department, and definitely not from a pre-hospital setting. One of the fallbacks, though, to giving some of these push dose pressors is what they have found even in the operating room is that people fail to do the initial things first. So they're not giving a fluid bolus initially. They're just moving straight to pressors, and that's probably not the right approach. So if you're going to add these things in, make sure that you've already done A, B, and C before you get to the end of the alphabet and the push dose pressors are being added into your arsenal. So don't forget to go back to the basics, take care of their airway, their breathing, their circulation. If they are hypotensive, they're tachycardic, give them a fluid bolus. As long as you've listened to lung sounds and we're not putting them into any type of fluid overload situation, then it would be appropriate to do fluid boluses first, and it really should be done first prior to the administration of epinephrine. So just something to think about if you decide that you're going to do push dose pressors. All right, so the dirty Epi Drip, this would be a situation where, you know, maybe you have limited people with you, you're trying to get some epinephrine on board, and it will end up doing the same thing as far as your dosage. You should be able to do a dirty Epi Drip and get about 20 mics per minute to deliver, depending on the size of your angiocath, and I'll talk about that. So essentially what we are going to do here is you can take either a 1 to 1,000 or a 1 to 10,000 concentration. It really does not matter because both of those are a milligram. So you're going to draw up either your 1 to 1 or 1 to 10, and you're going to inject that into a 1,000 cc bag of normal saline. And what that will do is that ends up giving you a different concentration. What the concentration will then become is 1 mic per ml. And remember, we need 20, somewhere around 20 is an appropriate rate if you're starting an epinephrine infusion. So if you can just appreciate that for every cc or milliliter in your 1 to 1,000 or your 1,000 bag, you have 1 microgram of epinephrine attached to it if you have reconstituted and made this dirty Epi Drip, then essentially what you would do is if you're using an 18 gauge needle or angiocath, you can run the infusion wide open. So you can do the math. There's different information out there. Obviously, if we're using a 14 gauge short catheter, you're probably going to be giving too much epinephrine. If you're using a 24 and it's a longer catheter, you're not giving enough epinephrine. So if you can just kind of remember that an 18 gauge, if you run that wide open, you're going to be giving about 20 to 30 mics per minute, which is essentially where you want to be. So if you're using an 18 gauge, maybe back it down just a hair, and it'll put you more in that range of 20 than 30 would. But this is something that you could kind of fall back on in the event that you have limited personnel and you're trying to get epinephrine on board. Please understand that we are not suggesting that you just do this routinely on your own. You obviously need to follow your protocol, or at least call in and ask medical direction if you can start an epinephrine infusion. I will tell you that speaking to some of the ED docs, some of the older docs may not be familiar with the dirty Epi Drip. Clearly, the newer physicians that are coming out of residency, the younger group, they've been using this, I assure you, in their residency practice, so they're probably more familiar with it. Just call and find out who you get, and obviously that's going to be a little bit of luck of the draw. But if they give you the go-ahead, you'll at least know how to do it, and if they tell you no, then you should document that you did try, and you were advised by medical direction not to administer the epinephrine via an infusion. All right, and then mag sulfate is the second thing and the final thing that I actually want to talk about here. It's an anticonvulsant and an electrolyte, and it's basically made up of two different constituent parts. There's magnesium, and then there are sulfate anions, which are the negatively, if you remember, cations and anions. So there are two different things that actually make up the magnesium sulfate. It is a CNS depressant, and it's an anticonvulsant medication, and that's why we can use it in seizure patients. And I'll explain why we give this medication for some of the different things that we do. It also inhibits airway smooth muscle contraction, which basically is another way for saying it will block the airway from contracting, which may be a good thing if you have a patient that is having some difficulty breathing, i.e. an asthma patient. So some of the indications here in a clamptic setting, so remember we have preeclampsia and then they have eclampsia, and eclampsia is when seizure activity has actually taken place. So mag sulfate is the medication that is recommended in those situations. If you have benzodiazepines, you can try it, but it is not going to work because it's not the correct mechanism. It's probably not necessarily going to hurt, although it may cause some respiratory depression. But if you have magnesium sulfate, obviously that would be the drug of choice for your patient that is in an eclamptic situation. Hypomagnesemia, so what that is, as the word says, it's low magnesium levels. So magnesium replacement would be a wise thing that we could potentially do. We know about torsades de pointes, or polymorphic VTAC is another way that you may call that or see that. Poly meaning many, so it has those many variations, but it is a regular rhythm. So we would oftentimes call that or refer to it as torsades de pointes. And then ultimately asthma. So those are the indications for where you can use mag sulfate. You obviously go back to the protocol, follow the protocol, and these are in the Northern Kentucky or the Swanky protocol as far as magnesium sulfate is concerned. Some of the contraindications you may think about are heart blocks or recent MI. If they have hypotension or if their magnesium levels are high, then clearly we would not want to be continuing to give magnesium to that patient. And it is a special consideration pregnancy category A, and I'll talk about that here just in a second, just briefly. So when we look at what the indications are from an eclampsia standpoint, the way that this medication actually works is it is thought to trigger cerebral vasodilation. So the blood vessels in the head actually get bigger, and that is going to cause a reduction in cerebral ischemia, which they think is caused by vasospasm. So the vessels in the brain actually start to spasm in your patient that has an eclampsia situation. So if we can cause cerebral vasodilation and allow for better oxygenation to the cerebrum, it is thought to reduce the seizure activity that is going along with that. And that is why magnesium sulfate is often recommended in your eclampsia patient population. If we're talking about hypomagnesemia, clearly we're just going to give it as a replacement. That is not something that we're probably going to do in the pre-hospital setting because most of us are not going to know what the patient's magnesium levels are to begin with unless they have these other signs and symptoms that kind of go along with that. Torsades basically torsades is an influx of calcium. So we know that calcium causes stimulation of muscle. And if you have a bunch of calcium influx, then you're going to end up having a more irritable heart. So with the torsades and the administration of the magnesium helps to decrease or reduce the amount of calcium ions that are fluctuating in. So hopefully that the patient is going to end up going from a torsades back to a normal perfusing type rhythm. From our asthma perspective, it's thought to have effects on both inflammatory and bronchodilation standpoints. So it is a good medication if the other mechanisms have already failed. If you've tried to do Adrenergic, maybe you've given them corticosteroids and that has failed to work, then magnesium sulfate would be something that would be a little bit further downstream. As I mentioned before, we don't want to just necessarily eliminate your albuterol and your ipratropium or your solumedrol, but it is another medication that could be in your arsenal, especially if you're working in a situation where you have a long transport time. You could think about giving mag sulfate for your asthma patient. And then as far as the pregnancy category, this is a pregnancy category A, and I just kind of wanted to review this because any medication that you take, if it is a prescription for sure, there is a pregnancy category that has been assigned to that, and it goes A, B, C, D, and X. So A is meaning that there is no risk to the fetus. They have done studies on this, and there's no evidence out there that suggests this is going to be problematic to the fetus itself. If it is a pregnancy category B, it's still maybe appropriate to give, but the studies that have been done were animal studies primarily, but the animal studies are now showing that there is no risk to the fetus. So they haven't really trialed it on humans, but at least in animals, there hasn't been a big problem with it. So we're going to say that this is a pregnancy category B. If it is a pregnancy category C, then they have done animal studies and they've had adverse effects. So we know that at least in animals, this is probably not a good thing, but we don't have a lot of data to support whether we should or should not do it in a human situation. So that would be your classification of a pregnancy type C. If it is a D, there is evidence of human fetal risk. So they have had either feedback or they've done studies or they figured things out over the years that this is in fact going to cause some damage or harm to the fetus. So that would be an evidence level D. And then if it is an X, basically X is it should not be administered to any pregnant female. It's a risk-benefit analysis here, and the benefits are definitely not outweighed by the risk. And they have also found fetal abnormalities that have existed. So the difference between D and X is that it increases the risk for an abnormality. If it becomes an X, they're saying that there has been an abnormality. And they are clearly recommending that you don't administer any of those types of medications. So again, I know in paramedic school, studying medications that would have the pregnancy classifications, and at that point, most of you may probably have remembered or studied that, and then it kind of falls out of favor. So if you can just remember that A is good, and then the further down you go onto the line all the way down to X is going to be more harmful to the fetus. All right, so here's something that Brandon always says, and I won't steal his thunder there, but he kind of told me this, so I'll give him credit where credit is due. If you can remember 2 grams per heart, it actually is going to make it a little bit easier to remember what your magnesium sulfate dosing is. So if you can remember 2 grams per heart, then if you think about the reasons that we're giving it, such as asthma, in an asthma patient, we have 1 heart. So your asthma dosage would be about 2 grams. That's how much you should give. So for asthma, we're thinking 2 grams. It's diluted in 20 cc's of normal saline, and you would administer it over about a 10-minute period of time. And as I mentioned before, this is due to asthma that's refractory to conventional treatments, but it's 2 grams because you only have 1 heart for the patient that is suffering from the asthma attack. If we're talking about a patient that has torsades, again, this is an individual suffering from a torsades de pointes. They need magnesium sulfate. The initial starting dose is 2 grams. This is going to be diluted in 10 cc's of normal saline and administered over about 10 to 15 minutes. If you follow your protocol exactly, which is what we should be doing, but as you can see, we're diluting 1 in 10 and 1 in 20, you're going to be in the right ballpark. And then administer it over about 10 to 15 minutes. And again, this patient with torsades, 1 heart, so it would be 2 grams. If you are taking care of a patient that has eclampsia, however, clearly you're taking care of mom and you're taking care of the baby. So there are 2 different hearts there. So if it is 2 grams per heart, we now have 2 hearts. We're thinking 4 grams, and that is the appropriate starting dose for your eclamptic patient. So the way that we would do that is 4 grams diluted in 20 and delivered over 15 minutes. So all of them, as far as how much time and how much you should dilute it in, are going to be relatively the same. What you really need to remember, and where people get kind of tripped up, is how much do we give? Is it 2 grams or is it 4 grams? So his way of saying 2 grams per heart is a pretty slick way to remember this information. So mag sulfate and asthma, and this can be used in the Swanky protocol if it is appropriate for you to do so. But there was a study done back in 2019. If short-acting bronchodilators and corticosteroids were ineffective, then IV magnesium sulfate was given. So they did go through the conventional mechanisms and it didn't work. So then they went ahead and progressed to magnesium sulfate. And what they ended up finding was IV mag sulfate in this patient population, as far as asthma, it reduced pediatric admissions to the hospital by 68%, and it reduced adult admissions to the hospital by 25%. So there is some evidence out there that magnesium sulfate is a good medication. It's a pretty safe medication. Clearly, we're giving it to your pregnant females, and it's a pregnancy category A. So it can cause some untoward effects anytime you're giving electrolytes. It obviously can cause some things to get out of whack, but I think as long as we're doing it within an appropriate range and you're putting it in after you have done your conventional treatments like your asthma and ipratropium and maybe your corticosteroids, the outcomes are actually pretty favorable in this situation. So it's something that clearly, as we move forward and the protocols get looked at, this is something that you may see become a little bit more prevalent in those situations. The pediatric dosage here is 50 mg per kg, and it's an IV infusion diluted in 100 over 10 minutes is how you would end up doing that. So again, follow your protocol, make sure that you understand how to draw these medications up and administer them in the event that you have to do so.